This is a private video for Marissa, and I did review the video that you sent me. My gosh, my shoulder was so much in the way. It's terrible, but when I have no videographer, that's what I get. Can't even supervise myself. You had the type 2 cuboid syndrome that I've written about, except very surprisingly was that you had no restriction in the ankle joint, which is called the talocrural, crura being lower leg. So the talus and the crura connect, all right? Now, when people do have that restriction, they will have a limit of passive dorsiflexion. People who are restricted like that, they can only bring their involved foot passively, someone else pushing, up to neutral or maybe plus 5 degrees, and then on the uninvolved side, they'll be able to passively dorsiflex them. You know, very observable difference, okay? So you didn't have that pattern, but the way I treat that pattern when present is I scoop the calcaneus. So think of a curve, okay? I scoop the calcaneus down and out as though I'm going to just purely rotate it, and I slide my right hand down the foot where I bump into the bottom of the talus and part of the tibia that carries it, and I just do little oscillations like that. I do 30 of those, and it responds beautifully. Then I come up half an inch and I test the tibia, and sometimes the tibia will be restricted. Now, there's no harm in you doing this treatment. You're not going to hurt your ankle by having someone gently but firmly do this to you. So, might be a worthwhile thing to go ahead and treat that in case it is involved this time, okay? So the sequence could be slightly different than what I did with you. Don't be concerned about that. The ones that are very key and very critical, I will do in the appropriate sequence. What I typically do after that mobilization is I stay in that region of the foot and I hook the bottom of the fibula with this nice little space between the hypothenar and thenar eminence. So it fits beautifully. I push gently to take up the slack, trying to move that fibula up towards the knee, and I then do 30 oscillations. But please understand, when I say oscillations, I mean that I've leaned into it firmly and I never let go of that firm hold. It's only forward from there. So it doesn't look like this. It's not bouncy bounce. It is take up the slack in that structure, get into that structure where everything's locked up, and then you've definitely input energy into those dense connective structures, and you sincerely get a little bit of joint mobility. So that fibula on this skeleton here is that long bone, and of course later on we'll review how we treated it from behind. But so that's that long bone, and we're working to restore superior glide, which of course is a proven accessory motion, although some people don't treat it, interestingly. So after I do that 30 times and I recheck to see if there's normative play, I then work on restoring posterior glide. I say that because most people will have a forward fixation of the lateral malleolus, the bottom of that fibular bone. So I test it, and if it in fact is restricted, the same drill, I'm mobilizing towards the floor. Occasionally, for reasons I don't know, the sprain pattern actually restricts it in the opposite direction. The way I test that is I curl my index finger underneath to test forward mobility. Can I firmly take up the tension in there and still get a little bit of spring mobility, like a very strong spring? If that's restricted in that direction, but it moves posteriorly, then I work on restoring forward mobility. Actually easier to do with a person laying on their stomach, with the foot slightly off the bed, and I stabilize the tibia, the lower leg bone, and I capture the malleolus and work on anterior glide. So for that one, you test test for it being restricted, stuck forward, and if it's not stuck that way, test to see if it might be stuck backwards. Might be easier to test it with the laying flat on, laying on your stomach, to test forward motion. Might be a little bit easier that way than curling your thumb underneath here. But much of this I have treated myself in the past for this pattern, and on occasion, rare occasions, we'll have to retreat. So I will translate this to how you would treat yourself, okay? Now you could at that point go up to the other end, which is the fibular head, and it can get stuck in both directions. You were stuck posteriorly. I test mobility here. It's just the only real bumpy thing here below the knee joint. So you could bend your knee. All right, if you bend your knee, you can see that it's below the knee. Okay, a couple fingers below the knee joint. All right, so you could test posterior mobility, and then you could lie on your stomach, and you can test anterior mobility, and that's what you were lacking in. And what's nice is this shaft is pretty accessible, so you can capture it with the whole palm of your hand. Okay, and of course it was on the right side, and that is the right side. I just happened to flip the whole critter over. So it would be something like this. Okay, now you do want to push laterally at least 20 degrees, because there is a lateral slope to that joint. So if you just push forward, you could actually be compressing the joint and accomplishing nothing. And that's true also for anterior mob of the bottom of the fibula. When you're doing it the opposite direction, it doesn't matter as much. So 20-degree angle laterally, and use the whole palm of your hand. You can take up the slack there, and you can lean on that for 2 minutes. I like 2 minutes here. Sometimes I oscillate, sometimes I hold. Why do I hold it up there? Well, you've got this thick interosseous membrane, and you've got all the fibularis/peroneal muscles, and so it has a lot of dense connective tissue, and it's really not designed to move a lot, and therefore it takes more energy to do a correction to restore normative motion there. So I like a 2-minute hold on that one, okay? So you could do that one in that sequence. Sometimes I finish here before I work my way up there. I'm not, sometimes you can go out of sequence and it's okay. Other times it's important to stay in the sequence. The next movement that I work on is to restore pronation, or you could call it medial rotation or arch flattening, where the arch of the foot flattens so the foot twists medially. That critter's not as mobile as this one. This one has elastic. So here's a right foot. So the navicular is this big bone here, which you'll feel that knob on your foot, and I'll show you on my foot in a short while. And it is really designed for rotation. It really does a lot of this medial lateral rotation. So you want to make sure that mobility is there, and once in a while he gets jammed up a little bit, and that reduces the rotation. So what I like to do is just grab the foot. Okay, don't get specific, don't worry about it. Just make sure you're grabbing the back part of the foot. Okay, so you just grab the foot, fits nicely. Okay, and you just twist it. Okay, but you also stretch it towards you. That distracts the joint. That creates some joint space. So you traction it towards you, pulling towards you just a little, and then you work on the rotation, and you do about 30 reps. But you also add, separately or together, an inferior vector. So you want to bring that navicular and the other bones, which are called cuneiforms, down. Okay, so you want to rotate it medially so the arch is flattening. So the right foot is rotating towards the left, but also you preceded that with a forward pull, then the rotation, but then you also add this inferior gliding. You want 30 reps of that in addition to the twisting. Then you've really prepped it gorgeously to where it is much easier to treat the cuboid. Now the cuboid can get stuck, okay? and you follow the outside of the foot, which is the fifth metatarsal, that's the long foot bone. So you follow it and then boom, you step off it. So now you know you're on the lateral part of the cuboid. So then you want to come up 1 finger width, and you come on and you put, just lay your finger right there and then come up 1, and you'll be on the top of the cuboid, and you want to jiggle that guy up and down and up and down and up and down, but progressively twist him medially. So it starts out looking like this. Now you're holding the midfoot in pronation after you've done the 30 up and down, 30 rotations with the distraction. You just hold it there, and then you come work on cuboid, and you jiggle cuboid up and down, 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 up and down, down, emphasizing the down, which, because you're on the medial border of it, this is cuboid right there. Because your contact is more medial, that will force it to rotate medially. If your contact was just on the lateral border, you're actually making the problem worse. I'll stop here and we'll continue filming.